All right. Are we all together
Perfect.
here? Okay. Sorry about that.
That's
All
all
right.
right.
So we talked about the prevalence in West Virginia. Again, the suicide rate amongst young adults. And I want to take a moment here to acknowledge that the circumstances again of college students that are on campus. I myself have two college students, youth who one is a junior and then I have a sophomore, and they're away from home and friends for the first time. They're living with strangers. They're working under really intense pressure. I know I'm preaching the choir here, but I've seen my own sons and definitely some of their friends, their mental health escalate during this transition. And I'll just use my middle son as an example. He is probably one of the strongest mentally people I know. I admire him. He's incredibly strong-willed and self-determined and has overcome a lot of obstacles. And not so much this year, but last year he had a hard time for a little bit. And it's just because, he's used to having the comfort of his parents and his brothers. And, I saw him hit a pretty low. He wasn't suicidal. We did have that safe, honest, and meaningful conversation about it. But, it was hard. And just for the parents, if you haven't ever dropped your kids off at college, it is not better from year one to year two. Somebody should have told me that. All of my friends who have been through that are not my friends anymore because it was just as bad year two as it was year one. But I think even this past weekend, it was Labor Day weekend, and we didn't get him this weekend. We're going to next weekend. And he goes to a really small campus in Kaiser, West Virginia. And he was just alone out on the soccer field, and we hung up and I cried and was just like, oh gosh, that was hard for me to share or see Caden like that. Why is it doing that? So anywho, I think that that's important, just to acknowledge that the conditions are different. So let's get into a little bit about what you guys can do on campus regarding and the why. So a lot of you who know me know that I do a lot of work with Michelle Toman. This is her brother, Jamie, who never returned back to campus after a break and died by suicide 29 years ago. And the name Jamie's Law comes from Jamie, but she would always say that it's not about him, it's about everybody that's on your campus today, to ensure that they don't have the same outcome and that we do better in regards to prevention. But that is Michelle when Jamie's Law was signed. And there's a lot of whys, there's a lot of reasons for that law, and it's been updated multiple times. And so this past, I guess, House Bill 3218, this past policy includes a lot of additional components for higher education. I'll just show these for purpose of your recording, but essentially there's mental health access. There's a requirement that you have the Lifeline on your websites. There's a requirement for information for incoming freshmen. There's a requirement for post-intervention plans or postvention plans. So it's the three prevention, intervention, and postvention components. Additionally, you might know that there are requirements that all your student IDs have 988 on them, which is the suicide and crisis lifeline, as well as we always promote the crisis text line as well, so that there's two resources to ensure that there's opportunity to access more than one resource if in crisis. So I want to talk just a little bit. Again, these are the components of what's required by your campuses this year. And if you need that, I can send it to you. But I want to talk a little bit about best practice for college campuses and higher ed. I'm going to briefly, because of the time, go through these fairly quickly. But essentially, this is the comprehensive approach through the JED Foundation of what it would mean to have a comprehensive suicide prevention, intervention, and postvention set up for your campus. There's 4 overarching themes, and that's enhancing the protective and preventive factors, and then the life skills, the connectedness, early intervention for those who need help outside of themselves via they could be traditional or non-traditional interventions, availability and access to clinical services, and then finally the environmental safety and means restriction. And I realize that that can be really difficult because of other legislations that have occurred, but those essentially encompass what we try to do in prevention. And it doesn't mean that it has to always be those traditional services. So in regards to developing life skills, the interventions targeted are for living and life skill education. There's strong evidence that SEL, even in higher ed, approaches with college students can prove well to enhance academic perseverance, self-esteem, connectedness, and belonging. So that social emotional learning is still a huge component of what you promote on your campuses. Additionally, connectedness is the #1 protective factor against suicide. So ensuring that we create social connectedness via in-person or virtually are really, really important. Research delineates the strong linkage between social isolation and loneliness and ruptures in the psychological, cognitive, and emotional wellness. So this is not just Barry Fawcett's soapbox, but it really is important that we ensure that there are safe and meaningful connections for college students, again, especially if they've left their friends and family behind. There also is a need to identify students at risk. You can do screening opportunities. You can train individuals in gatekeeper trainings on campus to identify others who might be at risk and reach out and refer. A lot of the times, this is multifaceted and should be done in all meetings. I will advise that if there's a screening opportunity, there needs to be some type of mechanism of referral or mechanism for response for intervention. So again, I come from a clinical background and believe very strongly in clinical skills, but intervention is a skill that anyone can do with appropriate training. Oftentimes intervention, I just attended a summit last weekend virtually, and Job's just talked about how we're missing the ball when we're not providing for an intervention. So a lot of times in our traditional clinical setting, we're taught to do an assessment and then we do a safety plan and refer to treatment, but the intervention is not being done. So I'm just was telling the group prior to starting that, I'm a key believer that we need to teach everybody how to do an intervention. So I spend a lot of time on the road ensuring that that's done. But that's a component that we need to ensure that we identify those who need our help. We also need to promote help-seeking behavior. And I always say, sometimes we need to know when we need help outside of ourselves. Sometimes we can handle things internally, but oftentimes we're going to need something else. And then I want to acknowledge that 80% of students who later die by suicide aren't seen by their counseling services. So for us to rely on students to self-refer isn't always practical. So having that universal messaging about asking for help, but not always but also leaning in and ensuring that those that perhaps are stronger know that we're here for them is very, very important. Preaching the choir here, mental health and substance misuse treatment services. So individuals who die by suicide at their death most likely have a diagnosable mental health or substance misuse disorder, and mental health is treatable, and so is substance misuse. So therefore, ensuring that occurs is really important. Crisis management services, so access to immediate emergency services and then longer term is really important. Again, we acknowledge the local and national crisis resources. So there is the Suicide and Crisis Lifeline 988, as well as the crisis text line, which is 741-741. And I've got some notes about this. all I really want to acknowledge in this short time period is that there's a safe and unsafe way to do everything. And suicide is about life or death. So it's really important that we get it right. And so we offer a lot of consultation and technical assistance services, as well as training resources to ensure that we're handling this right. But in regards to the crisis response after a suicide death, and hopefully, we don't encounter that during the course of this year or subsequent years, but there's a right and a wrong way and a safe and unsafe way to do that as well. It's called postvention. It's not prevention, but oftentimes that's what occurs. In my experience in doing postvention, the opportunities for intervention come up a lot. And it's a real thing. So contagion is the heightened risk for subsequent suicides after a suicide death's occurred, hence why it's really important to get the crisis response right. There's I guess, recommended guidelines for memorialization, talking points for staff and students. There's a recognized time period to do it because we don't want to ever get to the point where a suicide's glamorized or glorified, and that can cause more hurt than help. So there's a defined team you need to have acknowledged. You need to have the method of communication in regards to how you're going to communicate internally with staff and students, as well as externally with the community, and specific to the family, provide that kind of support. Again, there's guidelines for memorialization, and then there does need to be a clear vision of prevention efforts. I work to do suicide prevention more than anything else, so I'd like to be on the pre-end of that versus having to do the postvention, but it is important work that's meaningful and necessarily. In regards to lethal means reduction, this is sometimes a hard conversation, but absolutely imperative that it occurs. Again, in my clinical background, I was not taught how to have a conversation regarding access to firearms or medications or other means of dying by suicide. And it's, again, that missing component. I will share with the group that if you haven't participated, the Suicide Prevention Resource Center and Zero Suicide have a free training called Counseling on Access to Lethal Means. It's CALM. It's self-paced. It's not so easy to navigate, but the content is incredible. So that's, again, something I feel like we should have that conversation with anybody in our care, not just those with suicidal risk, because anyone could be in the potential threatening situation at some point in time and not having immediate access to means. Research says that will significantly reduce the likelihood that we lose someone to suicide. So in West Virginia, that conversation tends to occur around firearms most predominantly, because most of our people who die by suicide in West Virginia die utilizing a firearm. And I always say, and I have a huge campaign that we're doing this fall again, Protect Means Safety, because protect does mean safety. Most people have firearms to keep themselves safe, but sometimes you need to keep safe from your firearm, and we need to protect our means safety. So that's just a conversation that needs to occur. Yeah, right at 20 minutes. I want to acknowledge that I have a whole training center that I do independently outside of Prevent Suicide West Virginia. And additionally, in partnership with Brother Up, we do Safe Talk and Assist, Signs of Suicide. I have a locally developed gatekeeper training, Recognize, Respond, React. So lots of education that we can offer you if you would like to do any of that. We're happy to provide it for you. And these are just some resources you might utilize. So I've redundantly talked about the crisis text line in 988, but Vets for Warriors, a really great resource for those of you who have military service members and or veterans on your campus. It's a peer-to-peer crisis, I guess, response network. They do check-ins and they're great. I'm sure you're aware of Trevor Project and Trans Lifeline, but just want to ensure that we have a wide array of resources there. So I'll give a second for questions if anybody has questions that they want to ask.
Thanks, Barry, for the presentation. Really appreciate it. Carolyn added a couple of links to some of the resources you mentioned, so those will go out to the group as well. But yes, please unmute or put your question in the chat.
I have a question. Based on what you said earlier with regard to Jamie's Law, just did a quick search, and I see the bill originally passed in 2015, but it sounds like there's been some updates since then. Where can I find the most recent information on that, please?
Oh, you're on me there.
I got it. I'm trying to unshare my screen, or you could take me off of there. I can look and send it to Caroline to send out. Thank you. Or she might have it, but essentially, so in 2015, it was passed under the name Jamie's Law, and then whatever in office that housed that accountability piece dissolved. So it essentially is just the same law that repassed with the addition of 988 on the ID cards. So everything that was previously in place just got reiterated, and then they added 988. Yeah. Okay. So with the firearms allowed on campus, again, that's why it's imperative we have those conversations now, because that not only puts maybe students at risk, but those who have ideation at risk. So one thing that we could provide is firearm locks. I know that that's not the end all be all, but it is something that we're happy to provide for those who are willing to create a pause and not have it immediately accessible, as well as dissemination of some information. So if you need that, also sometimes you have to have some harder conversations. You know, Tylenol can be lethal. Over-the-counter medications we oftentimes don't think about. There is research that if you disable the original means or method, that individuals won't go to another means or method. We know suicide's a really acute time period. It can occur over and over again, a crisis, but that time period of elevated crisis is acute. So if we can just put some time and distance from the person, their means in that, it can be really effective way of saving somebody's life.
I put the link to Jamie's Law resources in the chat. So if you go to the HEPC homepage on the left-hand side, there's a button and it takes you to our mental health resources page that has the links to the code. So you can look directly at what's been updated there. And then it also has links to all of the public and private institutions and their mental health pages. So since that is part of the law, that each school has to have mental health resources on their websites, we've listed them all there. If you happen to click on your school and the link is not the best link, please let me know. Please send me the updated link. I think we updated this last fall. So if any of those pages have changed and you happen to see it, just let me know and we'll get that updated. Thank you.
And again, if you want any time for us to come on, I mean, I can't be everywhere all at once, but to come on your campus and do some outreach, we've done that. I know Michelle just was at Glenville. I'm going to go next week and do some outreach because we do have a college program called SAVE for kids, just to kind of know what to do, because unfortunately, not everybody's going to interact with their mental health system on campus, but we've all got each other. And so if we can create an environment where everybody can be responsive to suicide risk and get people to where they need to be, that's our best initiative going forward.
Mary, can you share a little bit more about SAVE and how people would get in contact with you about that, or how it differs from if they're doing QPR or other programs for students on their campuses?
Sure. So SAVE is more of an outreach program that we've developed. Like I said, I have a training center. I work 2 jobs. I do this during the day, and then I'm building the training center till the middle of the night every night. But it's just an outreach program that we give kids a card. They can even be trained to table on their own campus. And just a way that they acknowledge someone who's suicidal, validate them, extend safety, that thing. So it's new, but I know Michelle did it. It's one of our little babies at Glenville, and it was widely well received. And kids thought, okay, this is the way I can empower myself to help people. And again, I think the intervention training, anybody who would want to participate in that, it's really important. I truly believe that we need caregivers of everywhere on all levels to be able to intervene and help keep people safe from suicide. So anything like that, you just send me an email, and I'm happy to have a conversation with you regarding the array of things that we offer. And again, anything from Prevent Suicide West Virginia that's established there is absolutely in-kind training that we're happy to do, and then, share programs with you too.
There was one final clarification in the chat. Sean mentioned that he thought the firearms on campus was not until June of 24. Did that change? Do we know?
The only thing I want to say about firearms on campus is during this series, we do have planned, I think, for the April ECHO to talk about resources for firearm safety on campuses in anticipation of that new law going into effect. So Sean, that's my understanding, that it goes into effect then. And so then obviously would be for fall semester, but we are still gathering up resources for that, for campuses to be able to plan mental health wise. So if you have any questions, please do feel free to reach out to Barry about firearm safety. We did put the link for the CALM training. That would be a great training to share with others on your campuses in anticipation of that. And then we plan to share more resources in the April ECHO session.
Any other questions or comments? Okay, we'll be sure to share the links. Everybody will get the recording as well. If you have any questions or follow-up questions, please let us know. We can get those to Barry or email Barry directly. But Barry, again, thank you so much. We really appreciate your time.
No problem. And thank you guys for all the incredibly meaningful work that you do. As a mom with 2 kids on 2 different campuses, I really appreciate it.
Awesome. Okay, we are going to transition to the case or discussion forum part of the session. We have one that is from the other ECHO in Virginia, just to kind of get hopefully everybody warmed up. Again, we really would love people to submit a discussion topic. It can be just a question. A Q will do. That's kind of what our motto now. A question will do. That's all we need. We don't need it to be on a specific person or a group of people, just something to have a discussion after the didactic talk in the sessions, something that's happening and it matters to you guys. That's really what this is about. We want to talk about things that matter to what's going on your campus and in your role on the campuses. So we're going to go ahead and share this one. We'll go through it real quick. Carolyn's going to walk through it, and then we'll do the breakout rooms like we did last time. So that'll take a second, and then we'll all come back and wrap up. So Carolyn, give me 1 second. I'll pull the case up and you can take it away.
Thanks, Jay. While he's pulling that up, I just want to encourage you also, if you have a situation that you would like to hear a discussion on, but you don't want to present it yourselves, we also have people sometimes that just send a case to be discussed anonymously. And so you can get the benefit of sitting in the session and hearing others discuss it, but wouldn't have to necessarily do the case presentation. So that's another option too. We do have another Project ECHO that is in the state of Virginia that works doing similar things to what we do. And so they have shared some of their cases with us, de-identified as we have with them when we have permission. And so these are really similar campuses to what we have in West Virginia. So I will go ahead and kind of walk through this situation. And then if you all have any questions, just hold those for the breakout session. So first of all, there's some questions that they want to have answered, but Jay, could you scroll down, and I'm going to talk about the background information first. So on this campus, this is a 20-year-old female student who's a junior. The student disclosed that they have a personality disorder, and when they're stressed or overwhelmed, they have a tendency to black out and cut themselves. The student stated they were not suicidal and does not want to self-harm, but when they black out, they don't know what they're doing. And the student has been having this experience for a while, was used to it, and had been dealing with it since high school. They said that they have been on a number of medications, don't like going to therapy, don't benefit from therapy. The parents are aware and have taken the student to a therapist back home before coming to school. During one incident of blacking out and self-harming, there was a massive amount of blood on the floor in the sink. And I believe this was in the residence hall because that's one of the services on the next page that's checked. So other students have witnessed this student's behavior. And during one incident at the end of the spring semester, they had cut themselves to the point where they needed to go to urgent care and get stitches. So if you scroll down, what's been done so far, the care team members at the school and the wellness center met with the student. The student visits the wellness center after these incidents to get checked out. And I'm not sure what this entailed at the school where this happened, but it says there's a mandated assessment required for the student to complete. The parent has been contacted several times to have them help with care for the student. The counseling center has been involved. And after the incident in the spring, the plan was to have a group meeting with the student's therapist, the director of counseling, and the student's mom, and maybe any others from the care team to come up with a plan to ensure treatment and safety for the student and support. So that's kind of an overview of what's been going on. If you scroll back up to the top, you'll see the questions that they had. What would other schools do in a similar situation to best support this student? If this behavior continued, would there be a consideration to have the student removed from campus or school for the safety of themselves or others? What stipulations would you put in place that the student would need to adhere to, if any, in order for them to remain on campus with safety? So there were quite a few different departments that were involved. So if you scroll down to the bottom, you can see they had a care team, the counseling center, the dean of students, the health center, their threat assessment and or care teams were both involved, it looks like. And then residence life, because of where the student was living, outside community services, and the parents of the student. So with that, we will get ready to discuss.
Okay, yes, everybody just give me 1 minute. Just a reminder, you'll go into your breakout room. It's 12:38. We'll give it about 10 minutes. You'll get a message that we're bringing everybody back, and then we'll report out real quick, just the kind of general themes that were talked about, and then we'll wrap up. So just give me 1 second. Okay, here we go. Okay, thank you, everybody. We might be waiting on just a couple more people, but we can go ahead and get started. So I have the case with the questions, so I can relay the questions to you guys. And also, if you have any questions, I'll pull that back out. The only thing I'm worried about is sharing my screen. It's a little wonky in the breakout room, so if I need to, I'll try. But the main questions for this case was, what would your school do in a similar situation? What would you do if the behavior continued? Would there be consideration to have the person removed from campus for school safety of others? And what stipulations would be put in place if the student would need to adhere to have them remain on campus? So what would you guys do in this situation? Let's start with that one. Does anybody have any thoughts?
This is Tim Underwood at Glenville. It would probably be brought to my attention first. I would reach out to the student and try to get them to come in. If they did not respond, I would probably make sure it went to our behavior intervention team, which is new. And at that point, the behavior intervention team could basically kind of put teeth in it and mandate that she come in for an assessment. Again, I would assess for lethality, but I'll be honest with you, it's kind of a sticky area when you're into self-harm because it's not necessarily lethal. And I am not sure at that point. I would try to build trust and get her to come, but I don't know to what extent I would be able to get her to engage if she didn't want to engage and it wasn't lethal. So that's kind of where I stand.
Thanks, Timothy. That's great. Anybody want to add to that? Go ahead, Kelly.
I think on our campus, if it came to me, I would probably recommend that it go to the CARES team as well. What I've noticed recently is that there are students in this type of situation and others that may come see me one time, but they don't really want to engage in counseling. And my worry is if the CARES team says or thinks that they're in counseling, then when do I break the confidentiality to say that they're not? You know, it has to be a really high level. So this semester, I've really tried hard to recommend that people put in a care team request, because I feel like, and please tell me if you all think I'm wrong, okay? Because I really struggled with this semester a little bit. That if the CARES team puts a plan in place, that it just won't solely rely on the student being willing to come to counseling. So it might be that they have to check in with somebody else as well, especially for a student that's reluctant to use counseling services. It worries me that, you know, that there might be this perception that people are coming when they may not be. And I don't, you know, I think it puts us in a hard situation due to confidentiality with students. And then I think on our campus, if the behavior really continued and it started to impact other students' ability to live in an environment where they could learn and not worry about a student, then that's probably when we would talk about, you know, how they might be able to stay on campus. So does that make sense? Like, anyway, my goal this semester is to try to make sure that when students contact me directly or faculty, that I also, depending on the circumstance, would ask them to put in a care team referral as well. So there would be more than just one person looking out to make sure that the student is checking in and addressing any issues that they might have that they may not want to come, you know, to campus counseling to receive services.
So Kelly, I can just share that we do encourage our students, if they are engaging in self-harm or have express suicidal ideation or behaviors, we offer them the opportunity to be connected to our BIT team through an information release. Otherwise, if a student has come to the attention of one of the other BIT team members, they will automatically bring that person up onto the BIT team. If they're coming through counseling services and not on everybody else's radar yet, we don't bring them up, but we do offer them the opportunity to sign that release so that we can then get them connected. And that tends to be really helpful when they're willing to do that and when they are already connected with us, but when they're not, it is a sticking point.
Okay, well, that's what I meant to say. I had that in the spring where a student allowed me to do a BIT referral on his behalf, and that worked out beautifully. I'm really talking more about outside referrals, faculty and staff, hoping that a student will come and get connected with me when they may not. That's the time that I'm asking for them to also do a CARES team if they're reluctant to come.
Well, if we know that they're reluctant, we do encourage, that's when we encourage our partners who are connected to them to just keep not pushing, but keep, sharing that we are available. And then there have been times, and I'm not sure now that I'm thinking about it, this has been a historical practice where we've not shared information, but we have with the BIT team, because we know we're addressing at-risk students, stated whether or not a student was connected, but we don't do that outside of BIT.
Right.
Okay.
Thank you for that feedback. I guess, it's been a elevated semester so far with really students that have had very elevated issues, and some have not been willing to come to services. And, in that regard, I do try to encourage the faculty that's referring and has talked to the student, maybe to also do a care report as well, depending on the circumstances of the referral. So maybe I'm just having an off semester, so just disregard me.
No, we can't. This is why you're on the Echo. Ask the questions and see what feedback you can get. So, yeah. No, I can imagine that campus has got to be a little different just across the state, I would imagine, just with things starting up and all that's going on. So, yeah. Any other comment? Tim, go ahead.
The only question I would have, again, we mentioned about removing them from campus. I think possibly, as far as we would be concerned here, I think the only way that could legitimately be done, in a situation where it's not lethal, but it's more self-harm, is to what extent it's affecting those people around them and to what extent that behavior goes on. We did have a young lady here probably about 5 years ago who actually took a razor blade and cut herself about 150 times. And they were all superficial, but she was a bloody mess. And the EMS was involved in the hospital, went voluntarily, got back out and the like. And thank goodness she did engage with me and did come see me, and that behavior stopped. But I think I'm thinking that would be, at least as far as I'm concerned, the only way that you could even consider removing from the campus would be to what extent it's affecting those around her, because again, there are people who practice self-harm, and that's not necessarily lethality, and the question of whether or not you can mandate treatment or removal from campus at that time.
Any other comments or questions for the group? Can be around the case, cannot be. We got about 2 minutes left before we bring everybody back together. I saw on the case form they marked the parents were involved. Does that add what kind of layer does that add to a situation like that? I mean, I'm not a counselor or anything like that, but you hear these stories about the parents were involved, non-involved, they knew, they didn't know, all that stuff. How does that, complicate is probably not the right word, but it makes it more complex, right? Am I wrong?
And I would say in the vast majority of cases that I've worked with over the last 15 years, parents typically are not involved. That's my personal.
There are times where we have parent involvement and it is beneficial because they are either close to their child and adult child, and are, an effective part of the support system, provide the transport to emergency services when needed. Or at least are aware that, if a student is identifying that maybe they live on campus, but they can't keep themselves safe overnight, that they, know that the student might be directed to call them to see if that is an option to come home, or to have the parent come and take them home. So at times it can be really helpful. And then at other times it's just, we're not connecting with the parents unless it's reached the level that an emergency contact needs to be notified of a hospital transport.
Okay.
As a parent of somebody who is self-harm, I will add on to it that a lot of times if the parent is involved, it's because that parent's able to talk the student down or the child down. So if it's usually in their care plan, if there's a pre-existing condition, they'll have that care plan set up so that this individual may not be an emergency contact, but could be the contact just to try to talk them down out of a situation.
Thanks, Sean. No, Wendy and Timothy, that was all great responses. Well, I thank you for all the comments. This was great. We'll just do a brief report out when we get all back together. So I might call on a couple of you just to give a couple of little statements about what you said, but this was great. Really appreciate the interaction. So just give me 1 second. It'll give a countdown here, and we will be back together in one room. All right, welcome back, everybody. Hopefully that went smoothly. We didn't seem to have any technical issues or anything like that. But Carolyn, maybe does your group want to start with just a couple of points from the discussion?
Sure. There were a couple of things that the group brought up. One was just how much of a risk this is for the student, since the student is really not conscious during these episodes. And so they figured that this would probably on their campus end up being a referral to the dean of students or conduct, and that the student, if they couldn't come up with a safety plan or couldn't agree to a safety plan that they could consciously work, that they probably would not be able to stay in the dorms long term, just because of the safety risk for the student not being aware of injuring themselves. So we talked about that a little bit, but we talked about during this upcoming meeting that they were talking about having, really assessing what had the barriers been to the student being successful or getting something out of therapy in the past, because they said that that hadn't worked well for them. So really exploring that and seeing if there was another option therapeutically. We also talked about, let's see, who else we would involve. And the group mentioned that they would probably reach out to campus police, because if they hadn't gotten a call about this in the past, it's possible that they would. And they would want to make sure that campus police had a trauma-informed response if they ever did get a call about this student. And one person also mentioned that their community has a mobile crisis team, and that would be another resource within the community that could be leveraged to help this student connect either with a different therapy approach or to get connected in the moment of the crisis. So that's kind of a summary of what we talked about.
No, that's great. The second breakout room had similar discussions. It was really around getting them hooked up with a bit referral to a resource team, if possible. The other thing was making sure that they were going to the therapy sessions. A couple people mentioned, or they say they're going, but they're not really showing up. Is there follow up through there? And then, having some mandates, how would you allow them to kind of come back to campus and things like that? There'd have to be a lot of kind of hoops to jump through as far as sessions and things like that, the group mentioned that they would have to attend. Then I also asked a question about parents and just what that level of involvement looks like. And so a lot of great answers from sometimes it's a part of their care plan, and that they are the person that can talk them down in a certain situation, and that they are very involved, where others are not really getting notified until maybe they're going to the ER or something like that, a transport. So it just really runs the gamut as far as what could, their involvement be, since we did see it on the case that they were included. But I'll let anybody else from the group want to mention anything else. We've got a couple of minutes, but hopefully that covered it fairly well. Okay, well, we got about 4 minutes left. I just have a couple of announcements. First, great job by everybody. Thank you for the discussion and showing up for another cohort of the Campus Mental Health Echo. We really appreciate everybody's time. We know it's been a big change with the new system and that you guys have gotten on, but it's always the smoothest transition. So if there's any other issues, please let us know. We're working through them. We've done this with another project and have gone through the same thing. So usually by the second or third session, things are, pretty much ready to go and running smoothly. But so don't be shy if there is some issues with the new system and you just have questions. We're here to help. So just let us know. We will be sending out a recap like we have in the past. So that'll include the recording, the dates for the upcoming session, which will be on October 3rd. There will not be a slide deck attached to this one, like I mentioned before, but the recording will have all the information in there, as well as we'll share the links that are in the chat. So all those will be coming in the recap. If there aren't any other questions or anything like that, we'll go ahead and adjourn until next time in October. Okay. Take care, everybody. Good seeing everyone. We'll see you next time.